of the Leonard Institute, and I am thrilled to be kicking off today's conference. The COVID-19 pandemic has demonstrated that equitable access to healthcare depends on ensuring that all healthcare professionals can practice at the top of their licenses. We have this morning a very full agenda at this conference, and we'll be joined by experts from across the country, giving us the opportunity to critically examine the current scope of practice regulations and whether or not they meet community and public health needs. I would like to introduce Penn's Dean of the School of Nursing to say a few opening remarks. Antonia Villarruel is the Margaret Bond Simon Dean of Nursing and an LDI Senior Fellow at the University of Pennsylvania. Dean Villarruel co-directs the World Health Organization Collaborating Center for Nursing and Midwifery Leadership at Penn Nursing, and co-chairs the National Academy of Medicine's Roundtable on the Promotion of Health Equity. He also serves as co-chair of the Strategic Advisory Council of the AARP RWJ Center for Health Policy Future of Nursing Campaign for Action. Tony, I will hand it over to you.
Great. Thanks, Rachel, and hello, everybody. Thank you to LDI for bringing us together, and thank you to all of you for joining us today. What an opportunity we have to discuss expanding scope of practice at a critical time. COVID-19 has shown a very bright spotlight on how restrictive scope of practice regulations affect public health. Across health professions, we are seeing states temporarily modifying scope of practices or considering long-lasting modifications, not only meet increased demand for health services, but to do so in a way that assures the safety of the public. As we move forward into our discussions today, I want to share a few reflections. First, COVID has illustrated that professional practice is not static. It is continually evolving out of necessity, such as supply and emerging conditions, because of technology like telehealth, and because of innovation, think retail clinics, concierge services. Similarly, our practice acts also need to evolve. Secondly, overlap among professions is necessary. Yes, there are unique functions in professional groups, yet one activity does not define a profession, and we should expect that there could and should be overlap in scope of practice. For example, why can't dentists or dental hygienists also provide flu shots? For that matter, why can't a veterinarian provide a flu shot in rural shortage areas? Why can't a home care nurse or physical therapist also order durable medical equipment for a patient at home? Why can't a hospice nurse also legally declare someone dead? Why is that restricted in some states to a coroner who may never see the patient but relies on a nursing assessment? Why can't pharmacists also provide chronic illness management? Third, we should assume and promote collaboration between healthcare providers. Competent providers will refer to others to manage issues that require additional expertise. We have to do this now during a pandemic, and we will need to continue to do this post-pandemic. As part of the recognition of the World Health Organization's designation of 2020 as Year of the Nurse and Midwife. As the largest healthcare professional workforce in the world, this year was meant to amplify and advance the role of nurses in providing greater access to more efficient and effective healthcare. The COVID pandemic has certainly accelerated those opportunities, and we need to ensure post-pandemic that the skills and abilities of all health professionals are not hampered by unnecessary regulations, and that we are all engaged in providing accessible and equitable care. This morning, we're going to take an in-depth look at gaps in current scope of practice regulations across various professions and discuss how these gaps affect health equity and patient care. We will also explore how we might reform scope of practice to meet community needs even after the pandemic eases. I'm excited to get our panel discussion started, and again, thank you all of you for being here. Rachel, back to you.
Great, thank you very much, Dean Villarruel. This session is being recorded, just FYI. It is for internal purposes only and will not be posted publicly on the website. With that, I am very excited to introduce our keynote speaker, Professor Martin Gaynor. Martin Gaynor is the E.J. Barone University Professor of Economics and Public Policy at the Carnegie Mellon University. Dr. Gaynor is also founder of the Healthcare Cost Institute,
Thank you, Rachel. Thanks. That's a lovely introduction. My mother would be very pleased with that. And let me say that it's an honor and a privilege to be here and have the opportunity to participate in this very important and timely conference. And I do want to thank LDI and the Penn Nursing School and Dean Villarreal as well. So actually, my remarks are related to some of the things that Dina Villarreal said just a few moments ago. As everybody here knows, scope of practice laws have been the object of a great deal of contention. As I said, I'm going to approach this from a perspective of economics and competition policy or antitrust. There's been contention in almost every area one could imagine. Obviously, doctors and nurses, pharmacists, doctors and psychologists, dentists and dental hygienists, ophthalmologists and opticians, the list goes on and on. Now, while scope of practice laws can and do have very real and important impacts on medical professionals, my view is that the proper focus on consumers, in this case, the consumers here, that would be antitrust lingo, are patients. What intersections are there between health reform generally and scope of practice? As I'll tell you a little bit later, in my view, scope of practice is an element of health reform and a very important element of health reform. And has the response to the pandemic made a difference? Laws or regulations that restrict competitors or restrict competition is those laws should protect consumers. They are not there to protect competitors. So, for example, a key question in the healthcare sector, but in other sectors as well, are there significant health or safety issues that warrant a restriction? If the answer to that is no, then it's not clear that there should be a law or a regulation that restricts what competitors can do. It doesn't have to be just health or safety. There could be other issues. But if the answer to that is yes, well, then tailor those laws or regulations narrowly to address the relevant issue. Let consumers decide. Let the individuals who are benefiting or possibly harmed by using a particular good or service, let them be the ones who decide what's best for them and what they want. Again, we all know that these things can be and often are quite contentious. So, second principle, medical professionals should be permitted to do the things for which they are trained and qualified. Very simple. So, people should be allowed to practice and do the things for which they are qualified. I think that's a good thing for patients and a good thing for society. A corollary to that is that restrictions that impinge on medical professionals' ability to practice to the full extent of their capabilities should not be permitted. Those should not be justified, and they should not be incorporated in scope of practice laws or regulations. Patients should decide. Patients should have the ability to select the provider of their choosing. If dental hygienists can do a perfectly fine job as dentists, and they do not need supervision because they are soundly trained to do so, then patients should be permitted to choose whether they want to have their teeth cleaned by an independently practicing dental hygienist, or whether they want to have their teeth cleaned by a dentist. There should not be artificial restrictions on the ability of patients to choose. Casket sellers, hair braiders, turtle farmers, manure spreaders. Some of this is really unbelievable, and it's often very difficult to see how these restrictions on who can, say, braid hair for consumers protects consumers. So if there's an unlicensed person braiding hair, how are consumers harmed? Well, maybe they didn't get the full training necessary for braiding hair, and the braid doesn't look that good. With casket sellers, there actually is a pretty famous case about that, where there were some monks in the state of Louisiana, if I remember correctly, who had been making caskets for their own purposes, and gradually people found out about them, and they were good quality, and they weren't trying to make a profit, so they sold them inexpensively. And then the professional casket manufacturers and dealers brought a lawsuit against them in the state of Louisiana because they didn't have a license to make and sell caskets. So many of these licensing requirements do have real important justifications for the safety of the public. For example, licensing for engineers and medical professionals. You don't want people designing and building bridges that will fall down before they're expected. All bridges will fall down eventually, but you only want them to fall down when they're designed to fall down and not before that. So there are real justifications for that, but for example, licensing requirements for hair braiders is something that's hard to understand as protecting the public. Professional associations often have restrictions on competition. Some of the most famous of these are physicians. There are restrictions, part of covenants or ethics clauses. It's usually ethics clauses in many of these professional associations that restrict competition. Music teachers, for example, restricted on competing with one another. Again, there's a long list of these things. But in many of these cases, it seems very clear that the intent is to protect the existing firms in the market, keep out new firms, keep them from competing, and moreover, actually prevent existing firms in the market from competing with each other to benefit themselves. So the basic point here is, as you can see, I was going on for a while about this, is many of the things that we see here with scope of practice laws occur in other sectors of the economy. There are repeated attempts to at protectionist legislation or regulations where the protection is for the existing firms in the market. It's also important to incorporate flexibility because as the practice of medicine, and by medicine I mean very broadly here, not just what physicians do, but what medical professionals do, as that advances and changes, as there's innovation in various ways, these scope of practice laws should be flexible enough to incorporate that, and again, not unduly restrict people from doing the things for which they are qualified. So with appropriate scope of practice laws, what are the things that we should expect? That patients can choose medical professionals to provide the services that they choose. In addition, we can expect expansion in the supply of providers and the supply of services. In the short term, with appropriate scope of practice laws, existing providers can expand the supply of themselves. And so we expect supply expansion from those providers who are already in the market. In the long term, with appropriate scope of practice laws, since providers can do the things for which they're truly qualified, that should incentivize entry by new providers. So we should expect more providers entering the market in the medium to the longer term. So we should get an expanded supply. Next slide, please. As we get expanded supply, there are a number of impacts that I think we can expect. One of those, and a very important one, is the expansion of access. Of course, that's particularly important and relevant for disadvantaged, underserved populations and areas. What's likely to happen to access for these particularly disadvantaged populations as we really get scope of practice laws right. But I think we already know from existing evidence that the expansion of access will be particularly advantageous to these disadvantaged populations in disadvantaged areas. Having scope of practice laws correct will permit providers to specialize. So we can have nurse practitioners, dental hygienists specializing in the things for which they're trained and qualified. That's a good thing. So enhanced productivity can mean more supply of services for the same providers. So this specialization can be a real benefit, in my view, of getting appropriate scope of practice laws. providing lower cost alternatives. Typically, the medical professionals who are affected by scope of practice laws are lower cost than others. So nurses, for example, are lower cost than physicians. Dental hygienists are lower cost than dentists, and so on. And so, as we have expansion of supply by these medical professionals who are lower cost, then we'll have lower cost alternatives. And of course, that's to the benefit of patients. That's not necessarily the case. What will it really depend on the extent to which patients view the various kinds of medical professionals as close substitutes or good alternatives for one another. So the goals of health reform, or at least some of them, are pretty straightforward. We all know what they are. We want expanded coverage. So there are a large set of goals associated with health reform. With regard to scope of practice is one policy that's an important part of this constellation of health reform policies on its own. And I think it's a key part of health reform. And getting scope of practice laws right is important and beneficial on its own, but it also intersects with other policies. Scope of practice is not just an important element of health reform on its own, but intersects and interacts with other aspects of health reforms. Let me just say something briefly about the pandemic. As was alluded to in the opening comments, in response to the pandemic, there have been relaxations in licensing and scope of practice restrictions that will help in the goal of rationalizing scope of practice laws. Most likely, I expect, is that the benefit of retaining the changes that have been induced by the pandemic, and moreover, perhaps lead us to consider further reforms beyond those that were induced by the pandemic. Where do we go from here? Progress has been made in reforming scope of practice laws, and that's great. But there's undoubtedly room for further reform as we work to rationalize scope of practice laws. Pandemic-induced changes will likely provide leverage for further reform. My view is that addressing scope of practice should be seen as a key component of health reform. It can and should proceed independently of other changes, even if scope of practice reform interacts in important ways with other elements of health reform. I don't think that we should hold off on beneficial changes while we wait for other things to happen, right? We never want the perfect to be the enemy of the good, but as we move to make reforms in this particular area, that will make other changes work better, yet both that in the present and in the future. And last, scope of practice reform is about patients. We should let patients choose to the extent possible and not unduly restrict those choices. And I think these are goals on which everyone can agree. So again, I want to thank all of you attending the conference very much, and I want to thank the sponsors very much for putting on a conference on this very important and timely topic. And thank you for listening to me give over to you a few thoughts.
So it seems one of the barriers to the expansion of scope of practice beyond the economic barriers you discussed with the questions of competition related to the federal trade is the turf battles that have been waged often by physicians to limit the expansion of scope of practice among other healthcare professionals. Talked a little bit about the role of consumers in empowering consumers to help demand further access and access to non-physician providers or other providers in different settings. Can you talk a little bit about what the most promising approaches to overcoming these turf battles might be, if you have any insights into that?
Well, that's going perhaps a bit beyond my professional expertise. I'm just an economist. I'm not a political analyst or a system analyst, but maybe just a few thoughts. One, certainly I think consumers should be very interested in appropriate scope of practice laws because it should be good for them. And payers should be very interested in this, right? Payers would prefer to have lower expenses. And so scope of practice should be very much favored by payers. As far as physicians, I'm not in a good position. I mean, I'm a doctor, but not one who can actually help anybody.
Well, let me ask you a question which may be more over the plate for you, which is related to FTC response to scope of practice, the Federal Trade Commission. And this is a question again from the audience, which is how does the FTC view situations where some states refuse to allow licensure for healthcare professionals while many other states do allow such licensure? So what has the FTC response been, and have they been any effective in trying to encourage states to expand scope of practice?
Yeah, well, that's a good question. Thanks. As some people may know, the Federal Trade Commission has been very active in this area. Part of it is what's called competition advocacy, so providing information to state legislatures. That generally has to be requested by somebody. So what usually happens there is a legislator requests the FTC to make a comment on a proposed law or on some existing regulation that's under consideration, and the FTC then provides its perspective, and that can be quite helpful. In some cases, the FTC does bring a lawsuit. That's not the most common approach, but for example, there was a case that went all the way to the Supreme Court and was decided in favor of the FTC, in which I believe it was the state of North Carolina restricted the scope of practice for dental hygienists, and the Supreme Court decided that this harmed consumers and it harmed competition without any accompanying benefit in terms of consumer safety. So there are court cases that do get decided, and the FTC has been very active and continues to be very active in this area. Having said that, scope of practice legislation is something that is a state legislative activity and not a federal one. And so there are some limits on what the Federal Trade Commission can do with regard to scope of practice laws in the states. It certainly tries to provide information and evidence and advice where asked.
Some of the questions that are coming are related to the financial incentives related to scope of practice and how perhaps we could use market-based incentives to try and encourage expansion of scope of practice. So there's a question about whether or not fee-for-service inherently emphasizes the zero-sum game behind the scope of practice wars, and perhaps paying for value or outcomes might change those wars. It's sort of a follow-up of the question we talked about earlier related to alternative payment models. But I wonder if you had thoughts about whether fee-for-service is really part of the problem with scope of practice.
Yeah, I don't view it that way. I may be a bit of an iconoclast on that. And my view is that the problem is not fee-for-service per se, it's that the fees are wrong. So if you got the fees right, you wouldn't have some of the problems we associate with fee-for-service medicine. Now, of course, with thousands and thousands and thousands of services for which to set fees, it's very difficult to do that. But I think it's possible to set the fees right in a way that incentivizes everybody to specialize. So, for example, part of the problem that I think the person is thinking of is probably due to the fact the fees are too high. So physicians who are higher marginal cost providers find it profitable to pursue these services, as do nurse practitioners. So there you have some conflict. If the fees were set so that they covered the costs of nurse practitioners and provided them with a decent return, it would be, but were no higher than that, then many physicians would pursue things that they find more profitable, and you get more specialization. Value-based payment, again, it's one of these parts, alphabet soup of alternative payment mechanisms we've been talking about for decades. A lot of sizzle, not a lot of steak associated with these things. It doesn't mean they're a bad idea, and maybe we'll get it right, but as you can tell, I've got at least a little bit of gray in my hair. And I've been hearing stuff like this for a long time with relatively little payoff. So sure, of course, if we could find an alternative payment model that would actually work, maybe that would get things better, but I don't really think it's the fee-for-service system per se. It's the fees. Getting those right, I think, would address some of these problems. And while we're waiting for the right alternative payment model, maybe we can just work on addressing those fees.
Would transparency help encourage consumers to move to lower cost providers, including perhaps nurse practitioners compared to physicians, and could that help with the expansion of scope of practice?
So I'm going to say definitely. A lot of the evidence shows no impact whatsoever. Some of the evidence shows that people do things that seemingly are contrary to their own self-interest, even when they have price transparency tools at their disposal. But there is some evidence that does show some impact. A few years ago, I was on a work group for the Commonwealth of Pennsylvania on shoppable healthcare. And one of the things that we did in the work group is we asked a bunch of the insurers to come in and demo their price transparency tools. And we also had a couple third parties. And I'll be honest, most of them were just terrible, just awful. They were very, very, or you had to click 5 or 6 times even to get to that after logging on, and of course trying to remember what your password might be. I sort through a long list of scraps of paper that I keep by my desk. And so I think we're not there yet. But hence my answer definitely.
It's the answer to a lot of questions like that, I think.
Yeah, I'm sorry for being so negative. It's my job to put the dismal in the dismal science.
No, we appreciate your input today, and I think that we've learned a lot from you. We are coming up to the end of your presentation. I don't know if you had any sort of final comments about what you think the most promising way to move forward is looking in the future for scope of practice.
You alluded to this earlier, is that ultimately policy doesn't get made by analysts, it gets made by politicians. And so what can we do as academics, as analysts, as researchers? We can provide the best evidence and try and make sure it gets out there. But how to find sort of the political leverage on this, I don't really know. So there's been some discussion already. Perhaps the responses to the pandemic may provide some additional leverage in that regard. Suppose various states, as we know, loosened up some of the restrictions, and then after a while people find, hey, not only didn't this hurt anybody, this was really pretty darn good, and it helped in a very, very difficult and desperate situation. Well, that may go a long way towards retaining things.
Great. Well, I want to thank you for joining us today. I very much enjoyed your talk, and I think we all learned a lot from it. We are now at a 10-minute break in our programming, and we will be back at 9:30 with our first panel for today's conference. Thanks, everyone, for joining us. Welcome back, everyone, to the Scope of Practice conference. We are now going to moving on to the first panel of the day, which is a great panel on the current scope of practice of health professionals. Where are the gaps? With that, I would like to go ahead and introduce today's panel. Today's panel will be moderated by Matthew McHugh, who is the Independence Chair for Nursing Education, Professor of Nursing, and Associate Director of the Center for Health Outcomes and Policy Research at the University of Pennsylvania School of Nursing. He is also an LDI Senior Fellow. Dr. McHugh's research evaluates how nursing can be a force for quality, equity, and innovation in health services. Margot Brooks-Carthon is an Associate Professor of Nursing and Core Faculty at the Center for Health Outcomes, Policy, and Research at the University of Pennsylvania School of Nursing, and also an LDI Senior Fellow. Dr. Brooks-Carthon's research focuses on how the organization of nursing services affects health disparities among vulnerable populations. Jim Carney is Director of Advocacy and Government Relations for the Rhode Island Academy of Physician Assistants, where he previously served as president, as well as a member of the Public Laws Committee of the Rhode Island Medical Society. A practicing physician assistant for nearly 40 years, Jim recently retired from clinical practice, but remains active in PA advocacy, policy, and regulatory arenas. We also have Donald Chi, who is a professor of oral health sciences and the Lloyd and K. Chapman Endowed Chair for Oral Health in the School of Dentistry at the University of Washington. Dr. Chi is also a professor in the School of Public Health and the Associate Chair for Research in the Department of Health Services. And last but not least, we have Bianca Frogner joining us, who is an assistant professor in the Department of Family Medicine in the School of Medicine, also at the University of Washington, where she serves as the director of the Center for Health Workforce Studies and deputy director of the Primary Care Innovation Lab. Dr. Frogner's research examines allied health and the training and education of health professionals.
So now we're really lucky to have experienced practitioners and health services researchers who can talk to us about the current gaps that health professionals face. And so Jim, you've been working for a number of years as a physician assistant and in a number of specialty areas, including emergency medicine and behavioral health and critical care. Can you give us a sense of the current scope of practice issues that the everyday physician assistant is facing, and what are the kinds of barriers and the impacts on quality and care delivery?
There's been a lot of progress lately over the last couple of years in getting a lot of these restrictions removed from the laws. But I think one of the major ones is the tethering of a physician assistant to a specific physician. It may seem like, well, what's the big deal? But it does become very restricting as far as physician assistant mobility, about PAs being able to move from practice to practice or from setting to setting, working for a hospital or a large group practice, or transitioning to a solo practice. Every time they decide to move, or every time they decide to maybe take a part-time job somewhere, they have to go back to the medical board and refile everything that goes along with their license. The other aspect of it is that because of this, many states will not issue a license to a physician assistant until they have identified a supervising physician in that state. I think you can imagine that throws up a lot of roadblocks. This is faced a lot of times by PAs. So there are license. It's also other licensing issues. To give you an example, one state recently changed their requirements. They had a requirement that a physician assistant, in order to get a license in that state, had to have 3 letters of recommendation from a physician. So a new PA coming in, trying to get into that with the roadblock of, who do I get as a physician? And it really doesn't make much sense, that type of regulation. Another issue is PA to physician ratios. Many states early on had a ratio where of physician assistants to supervising physician, where a supervising physician could only supervise or collaborate with 2 physician assistants, 4 physician assistants, 6, whatever the number that they chose. And this again is a real restriction. It restricts practices and healthcare organizations from being creative in the way that they use physician assistants, especially in inpatient settings where you may have 10 or 15 physician assistants working for the Department of Surgery. How do you work with them and still stay within the law within the ratio? I know my first job out of PA school, we were faced with this. We had 7 physician assistants working for the Department of Surgery, and they really had to hustle to try and figure out a solution to that. They eventually came up with something that I don't want to go into the details of, because it probably wasn't really legal, or probably wasn't really a good practice. But that was how they got around it. The third one is practice agreements. Many states require that a physician assistant and a collaborating physician or physicians an agreement. Spells out exactly what the PA can do, what the PA can do, and many of them had and continue to have stipulations like guidelines for prescribing. These are a real barrier to PAs. The real kicker comes in that some states actually require that the practice agreement be on file with the licensing board, and the PA can't just change can't just change the guidelines at the practice level. They have to also go back to the board and file an amended practice agreement with them. And if something gets, and there have been cases about where this has happened, a physician assistant carries out, if he prescribes a drug that's not actually in the guidelines, and somehow that gets back to the board, they say, well, wait a minute, that's not in the agreement that you have on file here. It's a technicality. And most of the boards sort of turn in the states where they require this, sort of look at it and go, okay, we'll let that one go. But it really is a severe restriction. It doesn't practices to and organizations to work efficiently. And in some cases, it restricts access to care. The fourth one is distance restrictions. Many states early on, and still some today, mandate that the supervising or collaborating physician cannot be more than a certain distance from where the PA is practicing. This is a real pain in the neck, especially nowadays with telemedicine. For a PA that's working in Rhode Island and performing telemedicine, that supervising physician, who knows where that physician is. So many states have either increased the distances or eliminated that requirement altogether, as we did in Rhode Island. So that is one of the other big things. So those, I think, are some of the big barriers to practice. And as I said, they're more.
Thank you, Jim. It sounds like there's a tremendous amount of friction built into the system by all of these different rules, and I think that we're gonna come back to some of this. But I'd like to go to Donald and ask, from your perspective.
I think the secret is that we have enough dentists in the U.S. to go around. The real problem is that dentists are not distributed evenly across communities, and some communities have no dentists. And this is really where dental therapy and dental therapists come into the picture. Alaska was the first state in the U.S. to permit dental therapists to practice. And so they started practicing in Alaska in 2005. So it's been a little bit under 15 years now. So in a nutshell, dental therapists, they receive intensive clinical training to do a very set of dental procedures. Examples are exams, fillings and x-rays, simple extractions. And so kind of the bread and butter of dentistry that we think of, but they do practice under general supervision of a dentist. So similar to physician's assistants working with physicians, there is a dentist that needs to be not physically present, but dental therapists are not independent practitioners. And I think the points to emphasize here are really the limited scope of practice and the need to work under general supervision. And so what this means is that as long as there is a need for dental care, there will always be a need for dentists. And I think that this will be a point that I revisit. And this is coming from someone, I'm a dentist myself. And so I think it's an important point to reinforce that regardless of how many dental therapists there are practicing, how many states they're practicing in, there will always be a need for dentists as long as there are dental therapists. So dental therapists provide care that's no different from care quality provided by dentists. There's a lot of misinformation and unfortunately disinformation when it comes to the quality of care provided by dental therapists. And in my opinion, the resistance to dental therapy largely comes from dentists, but more importantly from organized dentistry. So I think that there probably is actually a lot of support out there from rank and file dentists, but it's organized dentistry that has put up a lot of resistance and opposition to dental therapy. And as it was mentioned earlier this morning, it's an issue of turf. I think that what does this portend for dentistry if we allow individuals with less training, if we allow them to provide irreversible procedures.
Margot, a lot of your work has really focused on nurses and especially nurse practitioners. How should we be thinking about scope of practice, and then what are the barriers that nurse practitioners face in terms of limiting how they can contribute to narrowing those disparities?
I'm going to take your last question first, which is, what are the barriers that prevent nurse practitioners from contributing to improving population health? So we know that there are over 200,000 nurse practitioners in the United States. However, they work under varying degrees of regulatory restrictions or scope of practice, depending on the states where they're employed. And these restrictions may impact their ability to evaluate, diagnose, or prescribe. And so in the least restrictive states, and so there are 22 of those plus the District of Columbia, NPs can provide care independently under the sole authority of the State Board of Nursing. And so some of this is going to sound familiar to some of the work that Jim shared related to PAs, and that in addition to the collaborative agreements, state practice laws often include additional requirements. So some states require that a physician has to be on site for a specified amount of time, while others have to be within a specified distance in terms of miles. And finally, some scope of practice regulations specify the frequency that nurse practitioners are expected to consult with a physician, and that too ranges anywhere from once a month to once a year. And so again, from an equity perspective, when we when I say we, I mean healthcare professionals and legislators, organizers say we're interested in rooting out systemic inequality and we're interested in anti-racism policies, we really have to evaluate those practices and regulations that restriction to nurse practitioners, particularly in their scope of practice, represents a prime example. And so to your question about how do we better utilize nurse practitioners to achieve equity, I kind of think the short answer is, let them work to the top of their license. But I think, a longer answer is that we already have some examples of how to nationalize scope of practice to reduce some of the patchwork, which leads to poor quality or at least variations in quality. If you look back to 2016, the VA instituted full practice authority. And so, no matter where you work in the United States, if you are an APRN in the VA, you have full practice authority. And similarly, in the face of COVID and the pressing needs of the nation, at least 22 states temporarily suspended collaborative agreements. And so when the health of our nation and the veterans are at risk, we've seen that we have the determination required to reduce or relax scope of practice restrictions. And so the question is, will we develop the same determination? And I think we have an opportunity to do so now. And the question is, will we? The work of health equity is hard, right? It really kind of calls for this decentering of ourselves. When we think about, for example, an equity model for the COVID vaccination, we know that certain people will go to the front of the line, the older, immunocompromised, Black and brown communities. And, it's equity is at the heart of that. It means all of us may want the vaccine at once, but we're going to prioritize. And so so that's a decentering of, yourself. But it also, for healthcare professionals, it doesn't mean we're all trained in the same way to do the same thing, that we bring our unique training to the table. And again, we have examples of that. I'm a classically trained researcher. I have a PhD, a BSN, a master's degree, postdoc training, but at the same time, I work with physicians who do not have that same type of training, who are involved in clinical research. So what if we, the PhD prepared, classically trained researchers, said, well, we want to, kind of be the arbiters of all research, and we want to lobby NIH and AARP to say only PhD prepared researchers should do the research. Yes, our training is uniquely different, but to consolidate power in that way and to require the tethering of researchers to one another because we have unique and different training slows progress. And, as someone who's been a nurse practitioner for 20 years, it's kind of a turf war we've been having for far too long.
Thanks, Margot. I really appreciate that example as a researcher of kind of how we look at the research world and how that is similar and different from the clinical world. That's a really great example. And I also, when we talk about systemic inequalities, I think, given the examples that we've heard so far about the variation across states, this is not at all implicit. This is very explicit. It's baked into the system. Bianca, in a recent paper that you and an excellent group of health services researchers had in the New England Journal, you recommended ways of modernizing scope of practice regulations to make them more efficient. And you've said that some of these regulations are about protecting turf, and we've heard that in a number of areas throughout the morning so far. Can you tell us what kind of empirically, what do the data tell us about expanding scope of practice for a broad array of health professionals, including those we have here today?
7 of us who are directing the health workforce research centers around the country that are supported both by public and private funders, where we saw from our collective experience that the evidence has been growing around a number of professions that scope of practice is limiting access to care and unnecessarily so. And where we see probably the greatest body of evidence has been around nurse practitioner scope of practice and how relaxing scope of practice has impacted access to care especially in rural communities and as well as other underserved communities. Comparing the services provided by NPs versus physicians. And I think as states have relaxed their scope of practice, it has allowed us a chance to test to see whether or not relaxing scope of practice has had an impact on access by doing these natural experiments. Now, like as Donald pointed out too, he's been very involved in dental health professionals, scope of practice research, and again, there is a growing body of work, I think a lot done by Donald, to show that, again, dental therapists are able to provide just as good quality care as dentists. And similarly, Jim also has pointed out an area that we're seeing a growing body of research around physician assistants versus physicians, and that, again, relaxing scope of practice has, for the most part, really benefited patients. These are 3 excellent examples of health professions where we're seeing scope of practice debates, but I do want to point out that scope of practice debates are happening across a number of health professionals. And it's not always about one profession versus physicians. I mean, I think Donald's example is a good example of that. Physicians aren't even involved in that conversation. And that this scope of practice conversation happens between many different professions. But I'll just add to that that I have done some studies also around other workforce categories, such as the pharmacist workforce, and looking at the role that pharmacists can play. And I think one of the key things with pharmacists is that over the last decade or so, pharmacists have moved up to a doctoral level training program, and they're quite advanced trained at this point in time to provide clinical care. But the reimbursement landscape prevents them from being able to practice at the scope of top of their license. So it's not always only about state laws, but also about what insurers are willing to reimburse. And pharmacists are able to provide more direct patient care than what a lot of insurers are willing to reimburse right now. And this can be quite important given how many pharmacists are in the community locally and how often patients are regularly visiting their pharmacists and seek advisement from pharmacists around the prescriptions that they are receiving. And that this is a perfect opportunity to be able to capture those patients while they're there and give them this patient education that oftentimes pharmacists aren't actually allowed to do because they're not reimbursed to do that, and they don't have the time, therefore, to be able to provide that care. Similarly, I've also done some work around physical therapists. Sorry, it's still a little early for me. So PTs actually have direct, across all 50 states, all patients are allowed to have direct access to physical therapists as the first point of care. But despite the fact that all 50 states allow that direct access, and some with different limitations, patients still face barriers to see PTs because insurers do not allow patients to go directly to a PT. They require you to start with a physician first before going to a PT. So this is where, state citizens within states have already agreed that it's okay to go directly to a PT, but yet the insurers are following a different code of conduct. And this is can be detrimental to patients. I mean, in the example that I'm giving about PTs, in our study, we found that going to a PT first really reduces your likelihood of getting an opioid by 90%. And that's because PTs don't start by providing prescriptions first. They're not allowed to do so. And that's probably a good thing because they start with other types of care first that's less, that's more following actually with what clinical guidelines provide and start with other forms of exercise and stretches that are worth starting with first, and that the evidence is also, again, growing to show that those are good first steps for that kind of care. So, again, the point here is that the turf wars, unfortunately, as we see them, do happen across the spectrum of health professions, but it's not always about turf between that's happening at the state level, but also insurers as well as employers. So hospitals can also set restrictions that you may not find in other clinical settings, and that we need to elevate the conversation to go beyond kind of who should be able to do what and have this tug of war without putting the patients in the center first. And that's what our paper really called for, was also to put patients in the center of this conversation. That's really the goal here, is to allow every profession to be able to practice at the top of their license.
So I'll go to first Jim and then Donald and Margot from the practitioner's perspective. What can you tell us about how the publics perceive and their level of desire for care from physician assistants and dental therapists and nurse practitioners? So Jim, if you want to start, and then we'll go to Donald and then Margot.
Yeah, it's interesting that this should come up as a question, because this is an issue that the PA profession has been dealing with for a number of years. And actually later today, there may be a final decision on what the course is they're going to take on this issue. Many people, when I say people, I'm talking physician assistants, I should say, believe that the title of physician assistant is confusing to people, not only to patients but to legislators and regulators. They sort of see it as, well, you're only an assistant. Should you really be doing these things? So that's one of the issues. I have found in my 40 years of practice that I always get confused with a physician. I mean, I've had patients that I used to see on a regular basis on one of my jobs, and every time they'd come in and they'd refer to me as doc. So I don't know what the solution to that is. I think as consumers become more and more educated, they are catching on to the fact that a physician assistant is not a physician. But I think that is an area where we need to do a lot of education, trying to get the message across that, no, we're not physicians. We're trained the same, but we're not quite allowed to do all of the things that a physician does. So, I think it's as I said, it's an education issue.
I don't think that they care. Like, they want health care, and so some of these nuances that we're having between each other is just not something that's top of mind. So I'll say for nurses and for nurse practitioners, so I'll say two things. One, I think that nurse practitioners have done a pretty good job of kind of educating the public about what nurse practitioners are. And they also leverage the fact that nurses are well-known, well-trusted, well-respected. And so I remember 20 years ago when I was training to be a nurse practitioner, one of the things we did in our master's program is that we literally went out to legislators as students to teach them about, like, what are nurse practitioners, what's the role. So you can imagine, this is 20 years ago, but they've been doing this consistently. So nurse practitioners are, like, well trusted. Pretty much people know what they are and what they do. They're leveraging kind of the respect of, nursing. Nurse practitioners have done a good job. That's not to say that, they couldn't do more to educate the public or legislators about kind of what they do. But in terms of choice, I think communities, they won't care. They just want care and access to care. And I think that is clearly something that resonates among some of the populations that we've been talking about.
So can you say a little bit about reimbursement rates and how that might play? And I'm just picking up from a question that came up actually for Marty. Do you think if the reimbursement levels change, for example, for nurse practitioners, if the reimbursement rates were similar to physicians, would that impact the ability or for nurse practitioners to have a broader scope of practice?
Whether or not insurers may raise the reimbursement rate to be equal, I think one of the questions is whether or not an insurer could possibly do that as a way to test whether or not that could encourage more of a certain kind of provider to provide care. I think we see some of this, not from a reimbursement standpoint, but in the way we set copays, for example. That insurers currently set copays such that we set higher copays to see a specialist versus a non-specialist, which has a lower copay, and that could potentially drive the way we have patients behave to go see certain kinds of providers. That's actually something we are currently looking at to see how the initial copay may impact the first choice provider that you see. And actually, I think United Health insurance company, that company, I believe, is doing a pilot right now where they're trying to eliminate copays to encourage better behavior. I don't think those outcomes are out yet. But I think there's still so much open in this landscape to understand how reimbursement is tied to scope of practice discussions. And again, I think the data are becoming increasingly available through the use of, through greater availability of private health insurance claims data that will allow us to answer some of these questions.
COVID-19 and the opioid epidemic. And so, these are two kind of shocks to our healthcare system in a way. And as a last question to all of you, and we'll start with Jim again, can you tell us, from your perspective, how either or both the COVID-19 pandemic and the opioid pandemic, what are the kinds of gaps and opportunities that they've presented for scope of practice change?
I think that as far as the opioid epidemic, one of the things that was found early on was that there is a real lack of people who are qualified to prescribe things like buprenorphine. I'm going to use that as an example. For years, PAs were not allowed to prescribe buprenorphine, and to a lot of negotiations with states and the FDA and all the regulatory bodies involved, they finally saw the light, and now PAs can do that. But that was a huge roadblock. As far as the COVID-19, I think that has brought a couple of really good points to the surface. One is that PAs were very limited because of all the things that I talked about before about the scope of practice, the practice agreement, the physician ratios, all of these requirements really impeded physician assistants practicing. And what it took was governors in I think it was 17 states to issue executive orders, basically just throwing out all these requirements, saying, nope, we're not going to worry about physician ratios. Nope, we're not going to worry about practice agreements. We just need qualified bodies to come here. And guess what? The sky didn't fall because they removed all of these requirements. There doesn't seem to be any evidence that the patients were harmed because the PA did not have a practice agreement on file with the regulatory board in that state. So I think that
Jim, I just want to give the others an opportunity to answer because we're running short on time, but I'm going to go to Margot since Jim brought up nurse practitioners and that same question.
Right, and I think, Jim and I have a similar perspective in respect to the ways in which states were able to, comparatively almost on a dime, right? Like some of these practice authority debates have been going on for decades. And so within a matter of weeks and months, 22 states suspend temporarily their collaborative agreements. It's almost unreal. But so I think what COVID taught us, one, obviously from an equity perspective, it, highlighted kind of disparities that have been hiding in plain sight. And it also demonstrated the capacity for legislators to address these concerns through broadening access and capacity for healthcare providers to provide necessary care without the sky falling.
Well, great. Thank you guys so much. This has been a really informative panel. I'm a nurse practitioner, but I learned a lot even about my own profession, and so I appreciate all of this insight.
A great discussion, as Matt said. I think that we all learned a lot. So next up today, we are lucky to have a brief update on the state legislation and scope of practice. And we have Sydney Edlund here to give us that update, who couldn't be better suited to do so. Sydney is a policy specialist in the health program at the National Conference of State Legislatures. She leads the program's work on access to healthcare and rural health policies as they relate to healthcare workforce, tracks and analyzes state legislation, and provides technical assistance to state legislators and staff.
To no surprise, the coronavirus pandemic has dominated the healthcare policy landscape this year and will likely continue into 2021. Access to care is a challenge for many Americans, especially those living in rural and underserved communities. State legislators continually look for ways to increase access to care for these residents. Examining scope of practice laws has been among the top strategies used to address this need. Modifying supervision requirements, expanding the procedures a provider is allowed to do, or the type of practice settings practitioners may provide care in, are just some examples of what states were looking at prior to the pandemic. In response to the pandemic, several states have pursued scope of practice policy options aiming to enhance and protect the healthcare workforce out of concern that increases in COVID cases may overwhelm the healthcare system. These policies are still the same ones that were being examined prior to the pandemic. And a majority of these policies were through executive order and are only in place through the duration of the declared emergency. And we will see if states will make any of these changes permanent. I also want to highlight an NCSL resource. We maintain an external website called scopeofpracticepolicy.org, and we track scope of practice legislation across all 50 states, DC, and the territories for 8 different health professions. It's scopeofpracticepolicy.org. So nurse practitioners and PAs, physician assistants, increasingly address workforce shortages by providing care independently or with physician oversight. Incorporating these providers into primary and/or specialty care can help alleviate the pressures of physician shortages. Since each state has its own specific laws and regulations regarding the responsibilities of these providers, the range of services performed varies from state to state. During COVID-19, we have seen states modifying practice requirements mostly. Many states have waived or suspended supervisory or collaborative agreements for the duration of the emergency. After states of emergencies were declared, and in some cases even before the pandemic, several states modified statutory language, allowing NPs and PAs to allow more providers to practice in additional settings. Kentucky authorized certain licensing boards to waive or modify scope of practice requirements to allow healthcare providers like NPs and PAs to practice in all settings of care. As enacted, this is effective only during the declared state of emergency. So these maps show which states have suspended and or waived practice requirements for NPs and PAs. The NP map on the left shows which states have temporarily suspended all practice agreement requirements, waived select practice agreement requirements, have taken no action, or the executive order has expired. The PA map on the right shows states that have suspended or waived supervision requirements by executive order, suspended or waived all or partial supervision requirements by existing statute or regulation, only suspended or waived select practice requirements, and states that have taken no action. I would highly encourage you to visit the websites for the American Association of Nurse Practitioners and the American Academy of PAs for more information.
That scope of practice is a good solution to limited access among vulnerable populations. It also sounds like limited access among vulnerable populations may be a good solution to expanding scope of practice. So we can move forward with that.
So in this panel, we're going to turn to talking about the evidence, talk about current evidence around expanded scope of practice, and think about where the law is and more permanent ways to expand scope of practice so that the healthcare workforce and what people are able to do better matches the needs of the population, what can be done and what is holding us back. So I'm delighted to moderate this panel today. I'm going to turn first to Ed. And Ed, I want to ask you, looking at states that have implemented full practice authority for nurse practitioners or other professionals, as well as states that temporarily waived restrictions during COVID, what does evidence suggest? So we started with Marty this morning saying we should follow the evidence, right? And Sydney in the last talk said, well, the evidence will come out and we'll see different states may need different things. So can you tell us a little bit more about that? What does the evidence suggest about costs and benefits of expanding scope of practice? And if the evidence is clear that benefits outweigh costs, what is preventing us from moving forward?
Well, thank you, Allison, and thank you to all the organizers. This has been fantastic. As was pointed out by the keynote speaker in the previous panel, the evidence seems overwhelming to me as an economist that the benefits of expanding professional scope of practice outweigh the cost. Expanding and permitting medical professionals to practice to the fullest extent of their training is in the best interest of taxpayers. The states that enacted temporary waivers seem to be able to lower the death rate associated with COVID-19. And his estimates suggest that had Illinois enacted a similar waiver, that Cook County, the most populated county in the state, of course, where Chicago is located, would have experienced 8% fewer deaths.
So can you talk a little bit more about how antitrust law has been used to challenge the anti-competitive nature of some of these, of some of the state professional boards and regulations, and how you imagine it might be used going forward? Is it a useful tool? Where can it kind of work with some of the other tools that are out there?
So the answer to your question is that when the Supreme Court decided FTC versus North Carolina Board of Dental Examiners in 2015, it was a major blow in changing the political settlements. What the case did, and it had to do with teeth whitening businesses operating in shopping malls, that the dentist-dominated state dental board thought should be prosecuted as the unlicensed practice of dentistry without any specific state statute authorizing them to do that. The FTC got involved not just as competition advocacy. The FTC actually brought a case. It won at every level, and it won in the Supreme Court. And probably the only Supreme Court decision that in my career will be the decision I would have written had I been the justice deciding the case. And what the case held was very simple, which was that although a state professional licensing board is an arm of the state, if it's controlled by a majority of the profession it licenses, then it is actually subject to antitrust oversight and antitrust enforcement and antitrust private litigation under federal law.
So as an NP, I can have my Utah license and I could actually work in Florida. And so that's for all of it. Yes, indeed, we can dictate what our care providers do within VA, except for prescribing controlled substances. That's the piece that's still a problem for us and a challenge. But unfortunately, if a nurse practitioner is trying to do telehealth from California and they need to see a patient in another state, California is extremely restrictive. So we have those issues as well. We couldn't utilize our APRNs to the highest level of their education and training. But we were able to get full practice authority for nurse practitioners, the clinical nurse specialists, and also nurse midwives, which we didn't have any of, but I included in the regulation because I thought we're seeing a lot of female veterans. We need to add the midwives. So every VA facility in the United States has full practice authority for NPs, CNSs, and nurse midwives.
You've looked at primary care with regard to vulnerable populations and how federal and state regulations can affect access to care for vulnerable groups. Can you talk a little bit about your research and what are strategies for improving access to care for vulnerable groups, and also which populations stand to gain the most from expanded scope of practice?
So improved access to care is a critical issue, as we hear this morning. And access to care is a multidimensional issue. Who provide care to the vulnerable? And so the availability of nurse practitioners in caring for vulnerable populations and whether it can increase access to care in underserved areas. The NP workforce has huge potential to boost the primary care capacity to increase access to care. So we know that NP are the fastest growing group of primary care clinicians. So currently this year, there are 200,000 NPs practice in primary care. This number has almost doubled the projection of 110,000 that the HRSA estimate for the year 2025. And so what NPs play, in the primary care delivery. So this suggests that can increase access to care and is more effective at providing care for patients with complex chronic conditions. So removing unnecessary restrictions on scope practice can further increase productivity of their care delivery. The key role that NP play in improving access to care for vulnerable populations. Full scope practice linked with a higher proportion of adults having NPs as a usual source of care nationally, and the increased primary care visit with NPs.
So you end at a place where a lot of the questions pick up, which is the other side of the coin of what you're talking about. So you're talking a lot about access, and a lot of people have been asking about safety.
There are workarounds everywhere. They are non-transparent. They're hard to study. They are themselves suboptimal. And it's only by being explicit about the ways in which we have done these workarounds, call it an odd form of civil disobedience, that we're actually going to get the studies that we need. And part of COVID authority, it's been interesting, it's only been in a couple of states, but I think it matters, has given hospital settings more flexibility internally to accommodate in very licensed categories. And I think that's really essential here. Without raising huge controversial issues about institutional licensure and whether institutional licensure can bring institutional accountability, I think the fact remains we use all sorts of health professionals to deliver all sorts of specialized services. We just don't like to talk about it.
A nurse practitioner in a ER was able, per their scope, to order chemo, but why was that in there?
The medical staff governance, as Allison and everyone else kind of knows here, is professionally important, but it's really vestigial, and it's caused all sorts of problems as hospitals have changed their governance mechanisms, and as sort of the production of complex clinical services modifies itself to do better with a more complicated staffing mix, and perhaps to address social determinants and things like that. So I think there's so little attention that's been given to medical staff procedures in the modern era that I am thrilled that you're doing this.
What more needs to be done, in your opinion? So we are heading into a really rough moment now as the numbers start to peak and hospitals are reaching capacity again. And I think, let me start Ying with you on this one, because, as we think about this, especially from the perspective of vulnerable populations, what do you all think has been enough? And it could be, categorically what has been enough, geographically what has been enough, and what more would you want to see happen in the coming months? So Ying, starting with you, please.
Yes. On the so far 21 of 28 states without full NP scope practice regulation have temporarily suspended all restrictions or waived selective restrictions in response to COVID-19. So that gives NP more independent authority to practice. So this indicates states recognize that lifting these restrictions is urgently needed to increase capacity to respond to the growing COVID-19 pandemic. It may also create a condition in which states acknowledge the impact of these restrictions, especially on vulnerable populations. So my move to permanently remove these restrictions, at the end of September, California passed the legislation to grant NP independent practice authority. So I hope more states would see the effect and so follow the footsteps of the California and to expand scope practice for NPs and remove the restrictions for NP practice.
Ying, do you worry that this kind of regulatory shift might mean that poor, vulnerable patients of color are shuttled in one direction, and wealthy patients with access are shuttled in another? So you can imagine that that poor Black patients have a harder time getting access to a doctor than they did before. Do you think that is possible? And if so, would it concern you?
I would say all these changes creating some very positive impact. So so by removing those restrictions, they give NPs more authority to practice and more efficiently to practice. I think that increase, the access definitely, for the population, more because NP more likely, to practice in underserved area. So this definitely, would increase access to vulnerable population. So that is the changes that we would see want to in that direction.
Others' thoughts on kind of the question of access to care for vulnerable populations, for patients of color, or kind of your thoughts on COVID reflections more broadly. Bill, jump in.
Allison, let me invite you to modify your question. Obviously, talking about the inequities affecting patients is important, but so are the inequities affecting professionals and non-professional healthcare providers. I mean, one of the big lessons of COVID is not just the disproportionate burden on communities of color, but the disproportionate burden on healthcare providers of color. And these are the professionals we don't really pay attention to. I was just looking at some nursing home COVID-related mortality statistics where there has been basically 10 times the staff mortality among non-RN providers than among our providers. And that's not surprising if you understand the staffing mix in the typical nursing home, but we're not protecting those people. And we've been arguing about the license categories, and we've been, as my friend Marty Gaynor always focuses on, talking about access and efficiency and cost. And part of the injustice here, in my view, is not just injustice in terms of the lack of access and timely access and high quality for patients in communities of color. It's really how badly we've been treating the people who care for those individuals, particularly people who don't have the sort of income and education and political influence and license protection of a physician.
And so that's interesting. So I was going to ask you how you see that fitting into scope of practice or licensure. And so you think that the kind of the licensure categories or scope of practice provide some protection and and more kind of political voice than for other workers.
I don't think we have time to go into it in detail.
Penny, Ed, last thoughts. We have about 2 minutes left.
Oh, so just last thoughts. I know, I wanted just to mention, so full practice authority for NPs, we knew it would make it laws. So we really, this helped with our telehealth efforts. I was just going to say we're averaging 84,000 telehealth visits a week. 14,000 telephone calls a week. So by removing that scope of practice barrier, we are able to practice across state lines, and we have full practice authority from facility to facility. But the one last thing I will say, and some of you may not know, but we put an interim final rule into the Federal Register last Thursday, and it is actually, it's called Authority for VA Health Professionals to Practice Healthcare. And basically what this does is we're invoking federal supremacy to allow, and the APRs aren't a part of this because we already did it, we really were the example, to allow other people in our system, so psychologists, audiologists, the PAs are in here, RNs are in here, to allow them to be able to work to the top of their education, certification, and training, and the VA will be able to write the scope for these people.
We have one final session today, and that is Julie Fairman, who will be wrapping up the session for us today. So Julie had the unenviable job of listening into the entire morning and putting her thoughts together on her feet. Tell us what the future of health professional practice might look like in the post-COVID world. Let me introduce Julie more formally, and then I will hand it over to her. Julie Fairman is the Nightingale Professor in Honor of Nursing Veterans in the School of Nursing and an LDI Senior Fellow here at the University of Pennsylvania. Dr. Fairman directs the Future of Nursing Scholars Program at the Robert Wood Johnson Foundation and is an American Academy of Nursing and Philadelphia College of Physicians Fellow. Her research focuses on the history of advanced practice registered nurses and health policy as it relates to competition, scope of practice, and service models. So Julie, I will turn it over to you for your closing remarks today.
All right. Thank you, Rachel. Can you hear me?
I can hear you, but not see you. But that's okay.
It says my video's on, but that's okay.
I'll turn it on. Not sure why it's not working, Julie, but we can hear you. So why don't you go ahead?
Okay. Most of the research compared nurse practitioners to physicians in terms of outcomes, quality, and access. But by the late 1990s, we knew nurse practitioners provided high quality care to multiple populations. And as my mentor, Joan Lineau, noted, it was time to move on to examine models of care, the regulatory environment, and how different ways of providing care worked or really didn't work, rather than situating comparisons with medicine as the norm. So in the last 20 years, research has actually moved in the direction Joan indicated, and we now, as this symposium has demonstrated, have moved on from comparison studies to those that examine the regulatory issues that impose unnecessary barriers for patients to access the services of nurse practitioners and other health professionals. And as my co-author Dan Gilman and I have written, regulatory barriers imposed on many professions can be anti-competitive without any compelling public interest. Competition tendencies are illuminated in scope of practice regulations. On one hand, regulations are designed to protect the public by setting education, certification, and accreditation standards that assure the public that a provider has a basic level of knowledge and skills. But as we have heard today, this is not always the case. When scope of practice regulations are used by a profession to protect their market share, instead of or in addition to protection of the public, either through political alliances with legislatures or as a foundation for challenged changes in other professions' scope, they restrict other professions from providing a full range of services. And this is particularly dangerous when there's no evidence that the services provided by these practitioners harm the public or provide benefits that offset potential costs. This anti-competitive stance, which restricts services beyond the purpose of patient protection, can be used to control who can engage the public as providers at particular times and places, and many of the speakers have spoken to this, be it through regulatory definitions of providers that shape payment mechanisms, institutional privileges, or regulatory channels. Now, the nursing profession itself has used scope of practice regulations in the early decades of the 20th century, and most recently to limit the work of unlicensed attendants or patient care aides in patient settings. And new regulations offering title protection can also be seen in the same vein. Both physicians and nurses have used title protection. In Pennsylvania a few years ago, there was action on title protection of nurse, and in Texas, the title protection of doctor in response to the doctor of nursing practice trend. Nurses should practice to the full extent of their education and training. And the first of the report's 8 recommendations was to remove scope of practice barriers so they might be able to do so. The message and recommendations were based on a particular assessment that restrictions on scope of practice have undermined the nursing profession's ability to provide and improve both general and advanced care. But all occurred within an empirical vacuum, without evidence that the growing scientific content or length of clinical practicum made a difference in the quality or safety of patient care. Even so, medical licensure and scope of practice were built upon these pillars, which grew into effective anti-competitive strategies. So the speakers of this symposium have focused on several common themes of the consequences of particular regulatory functions in terms of scope of practice: decreased access, worsened health outcomes, lack of necessary providers, and cost. And I also think that Dr. Gaynor's focus on patients is critical to resolving some of these issues. And scope of practice restrictions on nurse practitioners and other health providers appear under-rationalized at the best, where they purport to rest upon patient protection concerns that are not based on demonstrated patient harms or empirically grounded assessments of substantial patient risks. Because restrictions on licensure and scope of practice may come at a substantial competitive cost, such limits should not be more stringent than patient protection requires. So in broad strokes, state policymakers should account for competitive costs when considering scope of practice restrictions. There should be continuity across the states in terms of regulations. And then lastly, it also raises an interesting ethical questions. For example, if full practice authority for nurse practitioners, physician's assistants, and dental associates are good enough for those in the military, on tribal lands, in medical underserved areas, they should be good enough for everybody, and vice versa. It helps us raise questions. For example, what are the opportunities this current environment has created to ensure scope of practice regulations do not enforce existing inequities in health systems in terms of access, workforce, and cost? As some people have noted, as Dr. Chia has noted, for example, some research regarding state dentistry regulations suggests that increasingly stringent licensing requirements may not be associated with better dental health outcomes, but may be associated with fewer dentists per capita. And these findings are compatible with Dr. Brooks Carthen's findings for nurse practitioners. Now, as Dean Villarruel noted in her welcome, COVID has forced us to examine some of the strategies and these strongly held beliefs in terms of who can do what, and many speakers have spoken to this, that a regulatory framework itself may enforce health inequities in our healthcare system. And COVID has really shaken the tree, I think, and illuminated the unstable foundation of our current regulatory environment. We are losing all types of health providers to this pandemic on a daily battle. And as they battle the coronavirus on the front lines, more and more are testing positive and becoming ill, without a reserve workforce to step in for them. This critical time, the public needs access to healthcare providers, including all types of health providers. Not only do we need them for our overflowing hospitals battling the virus, but to care for those who have ongoing health-related problems. And as nurses, we are part of the most respected profession, and study after study has identified nurse practitioners as highly qualified and effective health service providers. But not everyone has access to the full range of services that nurse practitioners in particular can provide. Early on in the pandemic, the American Academy of Nurse Practitioners urged governors with restrictive regulations to lift these very roadblocks that hamper patients' access to care providers. Without one, nurse practitioners may not be able to prescribe certain categories of drugs, admit patients to hospitals, fill prescriptions, refer patients to nursing homes, or order equipment for rehabilitative services. Pennsylvania's failure to remove the regulatory barriers, and in fact, Senate Bill 100 is now probably dead for this session, that would have relieved some of the pressure for the requirements of collaborative practice. It will continue to restrict the public's access to needed health services and delay their needed care. With barriers in place, patients will go without needed medications, such as inhalers or antibiotics, if the nurse practitioner cannot prescribe without a collaborative agreement. So what to do? Regulatory bodies are ultimately responsible to the public, and the public needs to join with all health providers and various organizations. In fact, the AARP and the state-based AARPs are incredible stakeholders in this conflict to take away regulatory barriers. Demand states should loosen regulations that restrict patient access to healthcare services. And the VA is such an incredible model for this. I'm in need, both states and the professions have to take the lead to help us all get the best care during this dire time. That is what the public wants, and that is what the public needs. Thanks.
Thank you so much, Julie. That was a great summary of the day, and I think as one of the people wrote in the chat, I can't think of a better way to end the day than have Julie Fairman do it for us. So thank you. I want to also thank all of the participants who were with us during the day today and the audience members as well. One last announcement is that we have a 1 p.m. conference meeting this afternoon, and you're welcome to join us for that. That program is a nursing-specific complement to this morning's conference. In that program, which will be more action-oriented, we will focus on promoting evidence-based policy in Pennsylvania with experts and stakeholders gathering to discuss expanding scope of practice for nurses and addressing regulatory barriers in Pennsylvania in ways that may be relevant to other states as well. So I just want to thank the LDI staff who helped put this conference on and made it a success at the University of Pennsylvania. And a final thank you to, again, our panelists, our moderators, all of our participants, and all of the attendees. It was great seeing you all here today, and I hope you all stay safe. Thanks.